So imagine stepping into a hospital for an MRI. You probably know the drill by now because it's one of the strictest, most universally enforced rules in modern medicine.
Oh, absolutely. It is totally non-negotiable.
Right. The tech asks you to take off your watch, your jewelry, your belt. They ask if you have any metal implants, any shrapnel, literally anything at all.
Right.
Because absolutely no metal goes into that giant donut-shaped magnet.
Yeah, and as a medical professional, that instinct is just drilled into you from day one. You look at a patient with metal, you look at the scanner, and you just declare the procedure an unacceptable risk. I mean, the fear is catastrophic damage to the heart itself.
Exactly. But now, I want you to imagine a scenario where you have old, disconnected metal wires, literally abandoned electrical leads, just sitting right inside your heart.
It sounds like a terrifying proposition.
It really does. And that tension, between an absolute medical rule and the messy reality of what happens when you actually put that rule to the test, that's our focus for today's deep dive.
It's a fascinating subject.
Yeah. We are looking at a 2024 retrospective study. It was published in the journal Radiology Cardiothoracic Imaging and conducted by researchers analyzing data from Banner University Medical Center out in Arizona.
Actually, just to be perfectly precise with our source material here, the journal did publish a minor erratum regarding this study recently.
Oh, right, about the location.
Yeah, exactly.
Right.
It clarified that author Roderick Tung's affiliation is specifically with the Division of Cardiology at the Banner University Medical Center Phoenix campus, not the Tucson campus like it originally listed.
Good catch. Tracing the exact clinical environment is definitely a crucial detail when we're evaluating medical literature.
Absolutely.
So our mission today is straightforward, but it's incredibly high stakes. We are going to investigate whether this long-held medical fear of putting patients with abandoned leads into MRI machines is actually justified by real-world biological data.
Right.
Or, and this is the really massive question, is it a theoretical myth that is secretly harming thousands of patients by denying them critical care?
And to understand the danger there, we first have to understand why metal is left sitting inside a human heart in the first place.
Yeah, let's unpack that.
So we are specifically talking about cardiovascular implantable electronic devices. You'll hear them called CIEDs. For you listening, this generally refers to pacemakers and implantable cardioverter defibrillators.
Okay, the standard heart devices.
Exactly. And these devices have two main components. You have the generator, which houses the battery in the computer, and that's usually implanted just under the skin of your upper chest.
Right.
And then you have the leads. These are highly specialized insulated wires that travel from that generator, they snake down through your major veins, and physically anchor into the muscle of your heart.
Right. So let's put this into perspective. A patient gets a pacemaker. A decade goes by. The wire might fracture, or maybe an infection develops, or, they just need a more advanced system.
It happens all the time.
It's basically like upgrading the electrical system in an old house. You have a wire running behind the drywall, but instead of ripping the drywall out to remove the old wire, the electrician just disconnects it from the power source, caps it off, and leaves the dead wire sitting inside the wall. Then they just run a brand new wire to the outlet.
That is a perfect analogy. In medicine, those disconnected, intact wires left inside the body are called abandoned leads.
And if the wire actually breaks off and just a short piece is left behind,
then they call that a lead fragment. The old wire is simply capped at the top end near the collarbone and left permanently inside the patient's vascular system.
But wait, if you know the patients are going to live with these wires for the rest of their life and they might, need an MRI later for a completely unrelated issue, why not just take the old leads out?
I know, it seems counterintuitive.
Yeah, it seems like leaving a hazard behind. Why leave the metal in the wall?
Well, because taking the metaphorical drywall out in this biological scenario is an incredibly violent and dangerous process. Removing these leads solely to make a future MRI safer exposes the patient to severe risks of morbidity and mortality.
Meaning severe surgical injury or death.
Exactly. Because over the years, the human body reacts to that foreign wire. It covers it in scar tissue. The process is called endothelialization. The wire literally fuses to the delicate walls of the blood vessels and integrates into the muscle of the heart itself.
Oh, wow. So it's less like a wire in a hollow wall and more like a thick tree root that has grown completely around and fused to a fragile underground water pipe.
Yes. That captures the mechanical danger perfectly. If you try to rip the root out, you shatter the pipe.
That sounds horrific.
It is. To extract those old wires, surgeons have to use specialized laser sheaths. They slide a laser over the wire to literally burn and cut away the scar tissue holding it in place.
Lasers inside the major blood vessels.
Right. The risk of tearing the superior vena cava, which is the massive vein leading to the heart, or ripping a hole in the right ventricle is really significant. A tear like that can be instantly fatal.
Okay, I get it now. So from a surgical standpoint, the safest option by far is to simply leave the wire alone,
Without a doubt.
which creates a massive gridlock in patient care later on. Because fast forward 5 years, and that same patient develops a severe neurological issue, maybe a suspected spinal tumor. Their doctor says, we need an MRI immediately.
And that's where the system freezes. The current medical guidelines reflect a state of total paralysis on this issue. In the United States, the Heart Rhythm Society essentially states there is insufficient data to recommend MRIs for this specific population.
They just offer no clear pathway.
None. And the European guidelines give it a cautious Class II recommendation. That basically suggests a doctor can proceed if the benefits outweigh the risks, but they completely fail to quantify the actual probability of harm.
So it just leaves physicians guessing.
Exactly.
And the reason doctors are terrified to guess, like, the phantom menace hovering over this entire debate comes down to the invisible physics of an MRI machine.
Right, because an MRI machine, specifically the 1.5 Tesla scanners used in this study, generates a magnetic field about 30,000 times stronger than the magnetic field of the Earth.
Which is just crazy to think about.
It is, but the static magnet actually isn't the primary issue for these wires. MRI machines also use powerful radio frequency fields, RF pulses, to map the protons in your body and generate the image.
And the medical fear is that an abandoned wire will act as an antenna inside the chest cavity.
Precisely.
It gathers all that invisible radio frequency energy. And because the wire is capped at the top end near the shoulder, the energy has nowhere to go but down. It travels the length of the wire and concentrates entirely at the tiny exposed metal tip anchored right into the heart muscle.
Which is a terrifying visual.
Right. If you've ever felt your phone heat up while downloading a huge file, imagine that thermal energy magnified and concentrated into a point the size of a pinhead. The fear is it will literally boil the surrounding tissue, causing a severe myocardial burn.
And this fear was heavily reinforced by early laboratory studies. In vitro studies, which use artificial models, or phantoms, demonstrated severe heating.
How do they test that?
Researchers would take these wires, place them in a plastic tub filled with a saline gel designed to mimic human tissue density, and just run the scanner. The tips of the wires reached temperatures more than high enough to destroy human cells.
Wow.
Yeah. The lab tests indicated that the longer the wire or the more complex its shape, the hotter it would get.
Okay, so that brings us to the core of this Banner University Medical Center retrospective study. They basically wanted to know if the boiling gel in the lab actually represented a living, breathing human being.
Exactly. They analyzed a patient cohort from March 2014 through July 2020. They found 80 actual patients who collectively underwent 107 different 1.5 Tesla MRI scans.
Let's break down the demographics of that cohort, because I know they split them up.
They did. Out of the 80 patients, 67 had those long abandoned leads. The median length of those wires was a substantial 57 centimeters, and the median age of these patients was 74.
And the rest?
The other 13 patients had the shorter lid fragments with a median length of 5.3 centimeters and a median age of 66.
Okay, hold on. Let me push back on this a little bit. 80 patients over a 6-year period. If we are talking about overturning a global medical rule that dictates care for thousands of people, is 80 patients really enough statistical power to prove this is safe?
You know, it is a very fair question. In clinical trials, we always want thousands of data points.
Right. The more the better.
But because performing an MRI on these patients has been strictly contraindicated for so long, gathering any real-world human data is exceptionally rare. Most hospitals simply refuse to do it.
Ah, so just getting 80 is an achievement.
Exactly. The value of the study isn't just the sheer number of patients, but the rigorous, controlled environment in which they were monitored. It provides a highly detailed window into a practice most institutions won't even attempt.
The detail they went into is incredible. I mean, they didn't just note that the patients had wires. They meticulously documented the specific geometry of every single lead, because the lab tests warned that the shape of the antenna changes how much heat it generates.
What's fascinating here is their methodology. They used standard two-dimensional chest X-rays taken prior to the MRI to map the exact radiographic appearance of these abandoned wires within the chest cavity.
And they categorized them visually, which I was geeking out over. You had vertical fragments dropping straight down and horizontal fragments. You had wires shaped like a letter Z, leads resembling a lowercase r, some shaped like the number 7.
There are even coiled leads that look like springs.
Yeah, but the most common shape by far, accounting for 79 of the 97 abandoned leads they tracked, was C-shaped.
And the prevalence of that C shape is entirely due to human anatomy. The wire enters near the collarbone, sweeps down through the superior vena cava, enters the right atrium of the heart, and then hooks down and across into the right ventricle.
So it naturally forms a long, sweeping C to accommodate the biological pathways.
Precisely.
So the researchers have the theoretical risks. They have the 57-centimeter lengths, they have the C shapes, and they have 80 patients who desperately need MRI scans for their brain, their spine, or their abdomen. They are rolling these people into the tube. But they put major safety guardrails in place first, right?
Oh, absolutely. They utilized a very strict protocol. First, any active pacemaker or defibrillators still functioning in the patient were programmed into asynchronous or non-pacing modes.
Why do that?
This puts the active device into a safe mode, preventing the intense electromagnetic pulses of the MRI from tricking the pacemaker into thinking the heart is beating wildly. Because if it thinks that, it could deliver an unnecessary shock.
Got it. Second, they throttled the MRI scanner itself. They placed a strict limit on the specific absorption rate, or SAR. They kept it under 2 watts per kilogram.
Right. SAR is a measure of how much radio frequency energy the human body is absorbing during the scan. By capping it at 2 watts per kilogram, they prevented the machine from pushing massive amounts of thermal energy into the room.
Because if they let it hit 3 or 4 watts per kilogram, the antenna effect could theoretically multiply.
Exactly. And crucially, an ACLS-certified nurse or physician monitored the patient the entire time. ACLS stands for Advanced Cardiac Life Support.
Meaning they had someone standing right there with a crash cart, adrenaline, and defibrillators, fully trained and ready to restart the patient's heart if that wire burned the tissue and caused a lethal arrhythmia.
The stakes were incredibly high.
Okay, so the scanner turns on. The radio frequency waves bombard those 57-centimeter C-shaped metal antennas sitting inside the patient's hearts. Here's where it gets really interesting. What were the clinical results?
0 deaths, 0 clinically significant arrhythmias, and 0 adverse clinical events within the 30-day follow-up period.
Wow. The phantom menace just never showed up. No burned heart tissue, no catastrophic cardiac events.
It did not materialize. However, scientific integrity requires us to look at the minor anomalies, The process was not 100% flawless.
Okay, what happened?
After the MRIs, the technicians interrogated the active devices to see if the magnetic fields had interfered with the computer settings. Out of 80 post-MRI interrogations, 3 patients experienced a significant change in their device function.
3 patients, so that represents about 2.8% of the cohort. We should define significant change, though. What exactly happened to those 3 patients?
We are talking about changes in the electrical parameters the device uses to interact with the heart. For example, one patient experienced a 40% decrease in atrial sensing.
And sensing is the device's ability to listen to the natural electrical rhythm of the heart.
Exactly. Another patient had a 50% decrease in their capture threshold.
Capture threshold is the minimum amount of electrical voltage the pacemaker needs to send down the wire to successfully force the heart muscle to contract, right?
You've got it. And a third patient saw a 63% reduction in sensing.
So the extreme magnetic environment of the MRI just temporarily scrambled the software's ability to efficiently listen to the heart or determine how much power it needed to trigger a beat. Did those 3 patients require emergency surgery?
No lead or device revisions were required. These parameter shifts were managed entirely non-invasively.
How so?
A technician simply placed a wand over the patient's chest, connected it to a computer, and reprograms the software parameters back to their baseline settings.
Oh, that's it?
That's it. There was no physical harm to the patients and no surgical intervention.
So what does this all mean? The in vitro saline gel models screamed that a 57-centimeter C-shaped wire would gather enough energy to become a branding iron inside the right ventricle. But the real-world human data resulted in 0 clinical injuries and just 3 minor software glitches.
It's quite the contrast.
Did the researchers look at the data to see if the C-shape or the length caused those three specific glitches?
They did. They applied a statistical model called a multivariable generalized estimating equation.
Okay, think of that as a statistical stress test, right?
Basically, it allows researchers to isolate specific variables to see if one thing is directly causing another, while controlling for the fact that some patients had multiple scans. They plugged in the lead orientation, the lead length, the specific type of MRI, whether it was scanning the brain, spine, or abdomen, and the total duration of the scan.
So did the C-shape trigger the glitches?
They found absolutely no significant association.
Wait, really?
Really, the geometric orientation of the lead showed no correlation to device changes. The length of the wire showed no correlation. Neither did the type of MRI or the time spent inside the scanner.
So none of the physical factors that the laboratory models predicted would be dangerous actually translated into significant outcomes for these human patients.
None of them.
But if the lab models prove that radio frequency waves heat up metal wires and the living patients didn't get hurt, I mean, the laws of physics didn't just take the day off.
No, they certainly didn't.
There has to be a physical biological mechanism explaining the difference. Why did the gel boil, but the human heart didn't?
The physics became far more complex. The in vitro models failed because a plastic tub of perfectly uniform saline gel is a terrible substitute for human biology. The researchers highlight 3 distinct physiological defenses inherent to the human body that the lab models completely failed to account for.
Okay, let's break down that biological physics. What is defense number 1?
The human body does not present a uniform radiofrequency field. A lab phantom is a geometrically perfect container filled with a homogeneous gel. The human chest cavity is a chaotic, layered environment.
Yeah, you've got dense bone, pockets of air in the lungs, insulating fat, varying densities of muscle tissue.
Exactly. This non-uniformity scatters, diffracts, and alters the radio frequency waves, preventing them from cleanly coupling with the wire in the way they do in a perfectly controlled lab.
It's like trying to get a perfect Wi-Fi signal in a 100-year-old house with lead paint, plaster walls, and weirdly shaped hallways versus setting up a router in a massive empty warehouse. The signal in the house just gets disrupted and broken up.
That is a highly functional way to visualize it. And defense number 2 is perhaps the most vital missing piece from the lab models.
Wait, let me guess. The lab tests had wires sitting in a stagnant, unmoving tub of gel. But inside a living human heart, you have gallons of blood aggressively pumping over that wire tip every single minute.
Okay.
Does the blood flow itself act as a natural liquid cooling system?
You hit the nail on the head. It is active thermal dissipation.
That's amazing.
It is. Even if the tip of that abandoned lead manages to absorb energy from the MRI and begins to generate heat, the constant high-volume flow of blood at normal body temperature washes over the metal. It actively draws the heat away from the tip and disperses it harmlessly into the bloodstream long before the metal can reach a temperature that would damage the myocardial tissue.
The body is effectively water cooling the antenna.
Exactly.
That is such an incredibly elegant biological solution.
Yeah.
So what is the third defense?
Electromagnetic coupling from adjacent leads. These patients rarely just have one abandoned wire sitting alone. They usually have new, active wires implanted right next to the old ones.
Oh, right, because they upgraded the system.
Right. And the mere presence of those additional metallic structures alters the local electromagnetic environment. The active leads essentially share the load, reducing the total amount of concentrated radiofrequency energy that gets deposited into the abandoned lead.
The very things that make human biology so incredibly messy and complicated, the uneven tissue densities, the rushing volume of blood, the crowded pathways of wires, they actually act as a protective shield against the sterile theoretical physics of the lab model.
And if we connect this to the bigger picture, this realization extends far beyond cardiology. Why should a listener who doesn't have a pacemaker care about this?
Yeah, why should they?
Because it highlights a massive systemic flaw in how medical imaging and patient care are managed.
Right now, how are patients with these abandoned leads treated by the healthcare system?
Well, as the population ages, an increasing number of people with these devices are going to require advanced imaging for cancer screenings, neurological disorders, or severe orthopedic issues. But because of the ambiguous medical guidelines we discussed earlier, these patients are classified as having non-conditional devices.
And what does that mean practically?
Insurance companies and hospital legal departments look at that classification, cite reimbursement exclusions or liability fears, and they routinely deny these patients access to MRI machines.
And if you are denied an MRI, Your doctor doesn't just give up. You are forced to use alternative imaging, which usually means a CT scan.
Exactly.
But if you're looking for a tiny millimeter-wide tumor on a delicate spinal nerve root, a CT scan is like looking through a foggy window. An MRI gives you high-definition, 4K resolution of soft tissue. A CT scan simply cannot provide the same contrast.
I really can't.
So these patients are missing out on crucial, life-saving diagnostic information because the system is adhering to a theoretical fear rather than clinical reality.
Which is why this retrospective study serves as such a critical stepping stone. It provides hard, empirical data. It demonstrates that by utilizing a 1.5 Tesla MRI combined with specific careful protocols, such as capping the SAR at 2 watts per kilogram and utilizing continuous cardiac monitoring scanning, this historically contraindicated patient population is overwhelmingly safe.
It's a game changer.
It challenges regulatory bodies and medical societies to update their guidelines based on actual human physiology rather than relying on the artificial constraints of phantom models.
It really is a profound paradigm shift. I mean, for decades, the medical rule was treated as black and white. Metal wire plus MRI equals dangerous, unacceptable heat. But what this deep dive reveals is that sometimes the dynamic reality of the human body actually protects us from dangers that look catastrophic on paper.
It does.
The simple mechanical reality of flowing blood acts as a natural radiator,
Yeah.
cooling a wire that a stagnant lab model swore would burn a hole in a patient's heart.
It perfectly illustrates why translational medicine, the process of moving theoretical research from the lab bench to the patient bedside, is fraught with complexity. You cannot fully comprehend the resilience or the mechanics of human physiology until you observe it functioning within the human system itself.
This raises an important question for you to mull over as we wrap up today. We just spent this time looking at how plastic tubs and saline gel completely failed to predict the liquid cooling reality of human blood flow, resulting in years of denied medical care. As we move into an era of artificial intelligence and advanced biological modeling, how close are we to creating true digital twins of the human body? If we can eventually simulate the exact, messy physics of bone, fat, and flowing blood in a computer, will we finally be able to test these absolute medical rules without ever risking a human life? How many other medical myths are waiting to be busted by a better simulation? Think about that next time you hear a doctor cite an unbreakable rule. Thanks for joining us.